All right, so this video is going to be talking about our cardiovascular conditions. And so this is just another Humans of New York post that I like. So similar to when we talked about cardiac or pulmonary pathology for the cardiac pathology, some of the signs and symptoms can be a pathology in and of themselves and or a sign of other symptoms. And so we'll be talking about these in a little bit more detail related to the individual disease processes in the upcoming slides. But when we think about atrial fibrillation, again, this is its own condition, but can also be a sign and symptom of other ones where we see abnormal contraction of the atrial muscles. And this usually causes things like arrhythmias and ineffective pumping of blood into the ventricles to then get to the body and the lungs. We diagnose this with an EKG, and there's lots of anti-arrhythmic drugs and medications that they use to treat this. Just as we talked about cyanosis in the pulmonary, we can see bluing of the skin or the mucous membranes. And as a reminder, typically whenever cyanosis is related to cardiac, it is peripheral cyanosis due to low cardiac output. We typically see this in the fingers, toes, in the nose. And this is just the heart's not getting enough blood and getting that pumped out, versus the central, which is more pulmonary in nature, where we see the lips and tongue, mucous membranes in the face with low oxygen saturation. Dyspnea, shortness of breath, usually we see this with dyspnea on exertion with cardiac issues, usually caused by left ventricular impairment. With edema, we usually see this with CHF, which we're going to talk about. And when we see edema down in the legs because of CHF, it's going to be bilateral in nature and not unilateral. Fatigue often occurs with cardiac conditions with other symptoms and never really just by itself. Heart block, this is going to be issues with getting the neurological impulses through the myocardium the way they're supposed to, so they get interrupted. When they talk about heart block in terms of the classification, there's first, second, and third degree, with third degree being the more severe and where the signal is unable to reach the ventricles. Intermittent claudication is a result of peripheral vascular disease, or PVD, so you probably may have talked about that in relation to those types of diseases and human diseases. And we see legs are going to cramp at a certain point of time, and it's painful and can be limiting of their function. With chest pain, it's oftentimes either felt what we call substernal, which is below the sternum. People will put their hand right over their sternum and talk about it there. But we also know that chest pain that's felt within the left jaw, shoulder, and neck can be related to cardiac and specifically to heart attacks. Some people will talk about sharp shooting pain. Some people will talk about sort of like this heavy feeling. They may also have things like fatigue, nausea, vomiting, and paleness as well with that chest pain. Palpitations, this is going to be an irregular heartbeat, typically with a fast heartbeat. Someone might talk about feeling their heart racing or bumping, and it could be cardiac involved, but it could also just be things like stress, anxiety, or just too much caffeine. PVCs are premature ventricular contractions. And this is just going to be where we have a premature heartbeat of the ventricles. So it's sort of like somewhat of like a skipped or half of a beat. With this, it's a problem because if we prematurely contract the ventricles, we're not allowing it to fill correctly. And so this is diagnosed with an EKG as well, and it can be very serious if there's more than 6 at a time, but it is somewhat normal to have a PVC here and there in an EKG reading. A reduced ejection fraction, EF is ejection fraction, and this is looking at the efficiency of the left ventricle to get the blood out to the body. We see this with a variety of conditions like congestive heart failure, coronary artery disease, after a heart attack, and it's expressed as a percentage. It's considered low if it's below 70%. Syncope is lightheadedness or fainting related to cardiac nature, and this is going to be a reduction in the oxygen to the brain because of a decrease in the heart's ability to pump the blood. And then VFib is going to be similar to atrial fibrillation, but this is abnormal rhythm of the ventricles, and this is a life-threatening dysrhythmia or arrhythmia, and this is where we use the AED defibrillator to shock the heart back into the right rhythm. So the first condition we're going to talk about on its own is pericarditis. So remember, we talked about the different layers of membranes surrounding the heart. And so this is going to be an inflammation of the pericardium, which is surrounding the heart. And we see this typically after an open heart surgery, where they went in, they opened the pericardial sac and potentially introduced bacteria. This can be acute or chronic, and while it's most often due to bacteria, it can also be related to things like viral infections, fungal infections, and it's going to be treated with an antibacterial medication if it's bacterial in cause, or an appropriate medication for the other causes. But this is a sharp, sudden pleuritic pain, and usually we're trying to treat the underlying cause. So if it's bacteria, treat the underlying bacteria. While somebody has an acute pericarditis, PT is not going to be indicated because they are going to be on bed rest, but as it's treated, the prognosis is really good. You might work with individuals on improving their functional mobility, but there's not a specific PT type of intervention that's required. Myocarditis is going to be an inflammation of the cardiac muscle itself. Again, this can be acute or chronic. This is relatively rare, and they think there's possibly an autoimmune relation with this one. It can also have a variety of causes like viral bacterial infections. We also see this develop in individuals who have been positive for rheumatic fever in the past. Generally, these individuals are going to report fever, fatigue, shortness of breath, but you may also see that they have joint pain, they may have edema, chest pain, and orthopnea, so they're getting short of breath when they're laying down. Again, when they're in this acute phase, bed rest or antibiotics, if it's bacterial in nature, are going to be used. And again, the prognosis is good. However, this can lead to cardiomyopathy or ventricular failure. But similarly, in an acute phase, we're not going to be seeing these individuals because they are going to be on bed rest. However, if they're dealing with a chronic, we're usually working on improving their mobility and their endurance. The next one is endocarditis, and we see this inflammation and infection in the valves themselves or within the chambers. Typically, this is a strep bacterial infection, so they're going to use medications, antibiotics that work towards killing off strep, and the mitral valve is the most often impacted. This is problematic because it can lead to things like cardiac failure, but it is curable with early treatment, especially, again, if it's strep, to address that strep. They may also have things like pain medicine because of just sort of not feeling great with this, weakness, fatigue, night sweats, intermittent fever. They're going to use an echocardiogram. This can also be caused by individuals who share needles with drug addiction, and so this is relatively common in that population. So the next category we're going to kind of talk about is different diseases that affect the valves. And this is oftentimes caused by the endocarditis. Like I said, there's an inflection of those valves. So it's leading to other issues. And so the first sort of class of issues of the valve is going to be insufficiency and stenosis. And in insufficiency, we get regurgitation, which is sort of a backflow of blood. And this is due to the heart valve not closing properly. We usually see an increase in heart size with this and a reduction in the blood supply to the body. It can happen within any valve. Whereas stenosis causes an obstruction of the blood flow. It's the valve is unable to open fully, and the heart chamber itself has to push extra hard to keep a normal cardiac output. That obstruction and unable to open could be due to things like narrowing. So when we think about like plaque buildup or stiffening, thickening, and again, it can happen in any valve. We also see prolapse, and the mitral valve is the most often impacted. So we'll talk about mitral valve prolapse, or MVP. With this one, we see an enlargement of the cups, and they end up projecting into the left atrium. Any one of these can cause chest pain. Again, they're going to be diagnosed with things like an echocardiogram, EKG. Here's a picture here that kind of shows what regurgitation can look like. Versus when we have stenosis, it's hardening, and so it's obstructing the blood flow there. But regardless, we are forcing the heart to work harder. If it involves the pulmonary valve, it might cause right ventricular hypertrophy, which can lead to eventual failure of the right ventricle. If it's related to the aortic valve, left ventricular failure with resultant pulmonary edema. Symptoms usually are going to be that shortness of breath, and that shortness of breath laying down, fatigue, edema. We can see enlargement of the liver. Rales are going to be lung sounds that you would hear. And so depending on the severity of the symptoms, the treatment might change. So for example, individuals that have mitral valve problems or mitral valve prolapse, that is really common, and they can probably, most people don't take medications, don't have any issues, versus more severe cases require a heart valve replacement. And so there's about 65,000 heart valves that are replaced every year, and they can use donor heart valves for this. They can also use an animal prosthetic or prosthesis to do this. So pig valves are typically used. Individuals that have stenosis, insufficiency, or even more severe prolapse oftentimes receive antibiotics prior to getting dental work done. However, individuals that have sort of more asymptomatic mitral valve prolapse can get away without that at this point in time. One of the things that as a PTA that's worth noting is that if somebody is every time they cough or they every time they start exercising or they exert themselves and they cough without any type of pulmonary condition, like known pulmonary condition, could be due to a valve issue. It can cause some pulmonary congestion with exertion. So if you notice, they say, oh, I never really cough unless I'm exercising. It could be that they need to be referred back to their physician to get a cardiac workup. Our next condition is essential hypertension, or we commonly know this as hypertension or high blood pressure, and so just that persistently elevated blood pressure. This is very common. Obviously, we talk about this all the time. But the thing to get a diagnosis is that you have 3 separate readings that are elevated. They may hear what are called bruits, which are increased sounds of the blood moving through the abdominal aorta. Or through different larger vessels, and it sounds very like a strong river running through the area versus most larger vessels. When you listen to them with a stethoscope, you're not going to hear that. There is a variety of reasons why somebody might have hypertension. We know that some people, we can't really quite figure it out, or some people have more hereditary, but a lot of times it's linked to lifestyle choices. So just improving those can really help improve our hypertension. We know that this creates long-term issues if it is not controlled. So it can lead to things like decreased elasticity of the arterioles, which increases resistance to blood flow, which further increases our blood pressure. Some individuals are asymptomatic, whereas other people show signs of these vascular changes. Like I said, we might also see things like headache, flushed-faced, blurred vision. For a treatment, there's lots of medications that can be really helpful. Hopefully, individuals are counseled on changing their diet, exercising, and reducing stress. Decreasing salt intake, decreasing processed foods are really helpful. But then on top of those antihypertensive drugs, they can also use diuretics. Hopefully, individuals will make those changes, and generally physicians, before they give them the diagnosis of high blood pressure and start them on medication, will encourage a time frame of trying to make positive lifestyle choices to see if they can avoid medications. But ultimately, we do want to get this under control to avoid things like a stroke or other long-term complications. It is important to note that we talk about a high blood pressure as being anything over 140 over 90 as being hypertension, but there's actually multiple stages. Individuals who have a blood pressure of 130 to 139 over 80 to 89 are typically classified as prehypertensive. And again, this is on multiple different occasions. Whereas stage 1 is 140 to 159 over 90 to 99. And stage 2 is going to be anything over 160 over 100. Now, essential hypertension oftentimes is really responsive, again, to lifestyle changes as well as medications. But there is something called malignant hypertension, where the high blood pressure does not respond to medications to lower it. And typically physical therapy is going to be contraindicated in that individual, because we know that starting exercise is going to increase blood pressure. If we're already high and we're not responding well to medications, then that's not going to be a good spot for us to be in. This just shows some of the different things that high blood pressure, if left untreated and or chronically high, can lead to. And so things like heart disease, atherosclerosis, we can see angina, heart failure, eye damage, kidney disease, stroke, all of these things can be linked. We talked a little bit in the past about orthostatic hypotension, so we're going to kind of skip over this. This also might be called postural hypertension. So again, you can add that sitting in there. If an individual is really having a hard time and or is not able to get into standing. Some of the diseases that are affecting the coronary muscle and or circulation in and of themselves would be coronary artery disease. And this is where we see plaque deposits causing a narrowing of the coronary arteries, which then lead to an inadequate blood supply and can eventually lead to ischemia or no blood to that area in general. And so usually we see this caused by things like atherosclerosis, which again is that plaque buildup. But then individuals, depending on other lifestyle choices and or hereditary, are at increased risk of getting this narrowing of the arteries. Some signs and symptoms of coronary artery disease is going to be substernal chest pain. And substernal chest pain is oftentimes recognized by the Levine sign, Levine, Levine sign. And that's just going to be where they clench their fist right over their sternum when they talk about their pain. And that's indicating that substernal chest pain. And ultimately, this becomes an inadequate balance of oxygen supply and demand. So the heart's demanding more oxygen than what is being supplied. One of the causes is the atherosclerosis, and we can see this in other parts of the body as well, where we talk about arteriosclerosis. And so it can be a fatty material, like I eat way too many hamburgers every day, and that plaque builds up and is deposited. So not only does it narrow, but then it hardens over time, which doesn't allow the arteries to expand as needed and for changes in blood pressure. And again, we then see chest pain. But Unfortunately, the problem with all of this is that we don't see these plaques being built up, and we don't know they're there until there's a problem, typically. So it's best to avoid it happening. Another condition, sort of a further complication of coronary artery disease, is going to be cardiac ischemia. So we're restricting that blood flow. And this can be due to damage or insufficiency of the coronary circulation that supplies the myocardium. If there's, short-term issues, then there's going to be short-term damage or little damage, versus if it is a long-term issue, then it can lead to things like myocardial infarction. So really, when you think about this, you can think about how atherosclerosis leads to coronary artery disease. Coronary artery disease, as it worsens due to atherosclerosis, creates cardiac ischemia. Once we get cardiac ischemia, we can trigger a myocardial infarction, that heart attack. And we can also lead to things like cardiomyopathy. So these individuals are going to have chest pain. The pain can be referred to the neck, left shoulder, jaw. They're probably going to be short of breath. And that chest pain is going to be angina. And so this is a direct result of the myocardial ischemia. This is typically described as burning, squeezing, or tightness, and it's going to last less than 15 minutes in most individuals. If we're exercising with somebody and they experience angina, we're going to have them stop. We're going to have them take their nitroglycerin, which is going to be a little tablet that you stick under your tongue, so it's sublingual, and it works very quickly. And so hopefully then that chest pain goes away. And essentially what it is a vasodilator. And so it is going to dilate all the vessels in the body. And so getting a headache or dizzy is very common. So have people sit down when they take their nitroglycerin. Make sure that your patients are bringing their nitro with them. They should have it on them at all times. There's a couple different types of angina. So a stable angina is going to be sort of the classic presentation of angina. Somebody exerts themselves, they get this predictable chest pain. If they rest and take their nitro, it's going to go away. And we consider this a yellow flag because obviously we need to proceed with caution, and there might be times where we have to stop an exercise session, but it's not going to keep us from actually doing physical therapy with somebody. If somebody has unstable angina, this is usually due to coronary insufficiency, and they're at increased risk of things like heart attack and sudden death. This is not as predictable, and so it's more red flag for physical therapy, versus if somebody has an unstable form of angina called Prince-Metal angina. Prince-Metal, they have angina at rest. That is a definite contraindication to physical therapy. Increasing in severity here, we then have myocardial infarction. This is life-threatening, where we get a block to the artery, and we have prolonged ischemia causing death of tissues. Lots of different reasons why somebody might have a heart attack. Again, most of them are due to lifestyle causes. There is some hereditary factor, but just like everything else, lifestyle plays a huge role in this. Individuals may experience crushing chest pain to the left arm, neck, or jaw. However, it's important to note that women may also experience stomach pain, shortness of breath, nausea, lightheadedness. They may have swelling or fatigue. And because women experience this differently, women are less likely to go get assistance if they are having a myocardial infarction, which means women are more likely to die because of myocardial infarction. They might think they have some indigestion versus having a heart attack. So diagnosing it, history of a coronary artery disease or any of the other issues that we talked about that lead to this. They're going to do an electrocardiogram or EKG, ECG, same thing. And then there are some blood tests that we're going to talk about later this semester that look for cardiac enzymes in the blood to determine that a MI has happened. This is a medical emergency, so people need to seek care, and they're going to make sure everybody or everything in the body gets stabilized before we would start doing something like physical therapy. So this is just showing we have that plaque buildup. It's going to occlude the ability, and then we get cell tissue death. Another complication of a lot of the other things we talked about is cardiomyopathy. And in cardiomyopathy, the heart muscle itself enlarges and stiffens and thickens. And this enlargement is not due to working the muscle in an efficient way. It actually impedes upon the chamber size of the heart. So instead of being able to fill up a ventricle fully, that enlargement takes over some of that space, so you're getting less blood. This typically leads to heart failure and chronic diseases like long-term uncontrolled hypertension, lupus, celiac disease, end-stage renal disease, alcoholism, different viral conditions, and heart attacks can lead to cardiomyopathy. These individuals are going to be short of breath. They're going to have a cough, and sometimes it's a wet-sounding cough. They're going to have palpitations. They'll have edema in their legs. They may have ascites or swelling in their stomach. Angina, decreased urine output, lightheadedness, loss of appetite, deconditioned. Medications are going to be used to treat the symptoms of this, and we're going to work on improving someone's endurance. We can also see congestive heart failure, which is impairing the ability to pump the heart. So we call this kind of a circulatory congestion. If somebody has left ventricular congestive heart failure, you have to think about where the backflow goes. If it's not pushing out the left ventricle, it's going to flow back into the pulmonary system, creating pulmonary edema. So these individuals are going to have more breathing related things versus a right ventricular failure is going to stagnate and back up into the rest of the body. So we call this more systemic symptoms and or systemic edema. So we're going to see the edema in the lower extremities. And we also might see some enlargement of the liver. These individuals are typically short of breath with that cough. They have fatigue. They might just be kind of feeling sort of lethargic. They oftentimes have renal issues that are also going along with this, and they retain water. And so these are going to be treated with medications such as diuretics, which help pull the excess fluid off, as well as vasodilators to allow the most blood flow through as possible. With congestive heart failure, somebody might have compensated, which is a compensated congestive heart failure is going to be controlled with meds versus uncompensated CHF is not controlled well with meds. With these individuals, because their heart is already overloaded, we want to make sure that we're not elevating their legs over the level of their heart. That's going to cause the fluid that's in their legs, if they have right ventricular, to move back towards the level of the heart. Their heart's already overloaded, and this can create more issues. Another thing that from our perspective that we need to make sure that we're doing is not only working on things like strengthening and endurance. Walking programs are really great for these people. We need to make sure that we're checking in with them and monitoring weight gain. And so these individuals should be weighing themselves every day. And if we notice that they've had a 4-pound or more weight gain over the course of 2 days, we need to encourage them to speak with their physician. They may need to increase their diuretic and or it's a good indicator that they're going into a CHF exacerbation and may need hospitalization. So make sure you're helping monitor that weight. And then cardiac arrest. This is sudden, unexpected medical emergency. This might be due to things like myocardial infarction or VFib that we already talked about. We could also just have a circulatory collapse as well. This might be due to something like trauma or when someone has a lot of excessive bleeding. And so no respiration, pulse, loss of consciousness. We're going to start CPR, get them emergency help as quickly as possible. All right, the next couple of things are looking at electrical conduction. And so arrhythmias, we know that, typical heart rate is going to be 60 to 100 beats per minute. So technically, if somebody is below or above, then they are going to have an arrhythmia. Bradycardia can cause things like dizziness, weakness, or syncope. We see decreased oxygen out to the body. And oftentimes, if somebody has chronic bradycardia, they'll insert a pacemaker to help keep that rhythm going. And then with tachycardia, this can be due to things like exercise, which we would expect, or overexertion. But if it's prolonged, it can cause damage. So in the instance of things like ventricular tachycardia, this is going to be abnormally fast and can become life-threatening pretty quickly. And so these individuals with tachycardia prolonged typically are going to have an implanted defibrillator. So one increases, one decreases, but both pacemakers and defibrillators are going to control heartbeat. And again, we can have heart block, like I talked about. We can have first, second, or third degree heart block, which is keeping those signals from moving correctly throughout the heart. And then the AFib and VFib, typically AFib is between 100 and 175 beats per minute, whereas VFib exceeds 350 beats per minute. It is a significant medical emergency that they need defibrillated. Some of the blood vessel diseases that you might see, arteriosclerosis is going to be similar to atherosclerosis that we already talked about. So we have this thickening of the small arteries in the arterioles, which decreases the elasticity, which is also a problem of impeding the blood supply through that area. Usually we see these in individuals over the age of 40, and as we increase in age, the chance of somebody having arteriosclerosis also increases. Treatment, vasodilators, but then also making better lifestyle choices can be really helpful, just like the atherosclerosis. And atherosclerosis is just one type of arteriosclerosis. We can also see aneurysms. This is going to cause a dilation of the artery. With this, I'm going to actually just switch between here to show you the difference between an aneurysm where we see ballooning, which is the picture on the left, versus a dissection, which is the picture on the right, where we actually still see ballooning, but from the inside, it looks the same. The dissection causes a separation between the outer wall and the inner membrane, where we get a buildup of blood in that little pocket, which balloons on the outside. But whenever they're doing a catheterization to look in these arteries, they actually don't necessarily see the difference in the area compared to normal areas. Anytime we have bulging of a blood vessel wall, we're going to have weakened areas. And this can be from plaque, long-term hypertension. And most people don't realize they have it. They're asymptomatic until either somebody finds it and or it ruptures. A ruptured abdominal aortic aneurysm is very painful. It causes massive internal bleeding, and you have about 20 minutes to get somebody opened up and stop the bleeding in 20 minutes or less. The treatment is going to depend on the size. So some individuals, they're small enough that they just kind of watch. Sometimes what they'll do is they'll go in surgically and they will clean up the plaque. They will reinforce the area with stents. And depending on how quickly they find it and or if they have a rupture, the prognosis is going to be different. I had a patient several years ago who had a AAA. So we call AAA is a abdominal aortic aneurysm, and they were referred to physical therapy. This was when I was working in acute care, and I called the attending and I was like, you do realize you ordered physical therapy for this individual, and she is a massive AAA, and I probably should not get her up and walking. And he said, well, this patient is not surgical candidate. They know they're not a surgical candidate. They are okay with that, and she wants to be able to go home. I need to make sure she goes home. And he said to me, whether she ruptures here or she ruptures at home, she is going to rupture eventually, but I do need to make sure she's safe to go home. And so I said, okay, I guess we'll get her up. And I held my breath the entire time I was working with her, literally just did an eval to make sure she was safe to be able to get into her home, and stepped away because basically AAAs, especially large ones, are ticking time bombs. Another condition that you might see that's relatively common is thrombophlebitis, and this could be just an inflammation of a vein, and it could be something as little as just when you get an IV, you get if somebody has irritation around the IV, it could be a superficial thrombophlebitis. This, pain and tenderness, red. You can just let the nurse know that, hey, this is not looking good, and they can change that out. Versus more significant can lead to a formation of a clot, which can lead to a DVT, which then can lead to things like a PE or a stroke or a heart attack. And so anytime we think that we have this going on, we really should be making sure that they're referred to the right person to look into this. But it could be due to things like trauma, but it could also be due to things like prolonged immobility. So really, we want to make sure we're getting our patients up and moving. They might have that redness, that swelling, that tenderness in the area. We're going to elevate the affected limb, if possible, anticoagulants to help thin the blood to prevent a clot from traveling. And then some people will have bed rest. If it's a superficial thrombophlebitis, like an IV line, bed rest is not necessarily needed. Versus if somebody has a DVT, we're going to put them on bed rest until their blood is thin enough to safely get them up and moving. Peripheral vascular disease, or PVD, we talked about this a little bit earlier, how it can cause intermittent claudication. But this is basically due to the atherosclerosis, but down in the peripheral arteries. And we mainly see this in the legs because the legs are in a gravity-dependent position, and they the person is unable to really compensate by getting that blood pushed back up. We see this more commonly in older individuals, as well as people who have more uncontrolled diabetes, high blood pressure, or high cholesterol levels. Some signs and symptoms, depending on the severity, might be things like constipation or malabsorption, but again, we see that intermittent claudication. We could see cell tissue death, creating gangrene. We can cause issues of weakness long-term in more severe cases, just because there's not adequate blood supply to the area. This can be life-threatening in some individuals, but improving lifestyle choices can be really helpful, like changing diet and activity, but also stopping smoking and getting things like diabetes and high blood pressure under control can be really helpful. You will probably review this in your special topics class a little bit more about the wound care, but wound care and then working on endurance training is really important for these individuals. Some other venous diseases that you might see, CVA. We're going to talk about CVA and neuro, but remember that a cerebrovascular accident is actually a cardiovascular issue. We just see neurological complications, which is why we talk about it there. Some other things that you might hear about: patent ductus arteriosus, or PDA. This is going to occur in babies where we just don't close the connecting areas between the pulmonary artery and the aorta. Most babies grow out of this pretty quickly. Polyarthritis nodosa, we get nodule formations and inflammations within the small arteries. We can see this throughout the body, specifically more in the, like towards the fingers and feet. Raynaud's is a peripheral vascular disease. Plus, they have this intolerance to cold, which makes it a neurological component. Individuals' fingers might be really white. Brugger's, inflammation of the arteries and veins, and this can cause ulcer formation. So then we might be doing things like wound care with these individuals. And then again, DVT, pretty common. We need to keep an eye out for the signs and symptoms so it doesn't progress to something like a PE, but also remember that DVT, if it travels to the heart, can become a heart attack. If it travels to the brain, it can be a stroke. It's not just that it can only travel to the lungs. It's just usually it travels there first and gets stuck. Varicose veins are relatively common. These can cause fatigue, cramping, ache, and swelling, especially in individuals who are on their feet all day long. So that's going to be you here shortly. Wearing compression stockings can go a long way for that. And then when we're working with our patients that have them, we might do things like exercising in warm water. They can go in and they can pull those veins out. They can sclerose them where they put a sclerosing agent in the vein, which blocks it off so that it can't be used. And then vasculitis, which is going to be an inflammation within the blood vessel that ends up destroying the blood vessel. And we might also see phlebitis, which is an inflammation in that area as well. So those are just some terms to be familiar with. And then just real quickly, because the lymphatic system sort of mirrors the cardiovascular system, some of the diseases that might be present or you might hear about is Hodgkin's disease and lymphoma. This is a cancerous condition. It is malignant. There's a suspected cause by an illness, but they're not quite sure in most people what causes this. So it can also impact the spleen, the liver, and bone marrow. We get swellings of the lymph nodes like you see in this picture, but individuals also have other signs and symptoms of that we'd expect with cancer, like fever, weight loss, fatigue. They may lose their appetite. They might also experience hair loss and neck pain because of this. So chemotherapy and radiation, because it is a cancer diagnosis, are going to be important. So we might be working on improving strength and endurance with these individuals. Lymphangitis is going to be acute inflammation of the vessels, where lymphadenitis is the inflammation of the lymph nodes. So just slightly different presentation. But because it's an inflammation and infection in this area, you're going to see things like fever, pain, just generally not feeling great, headache, swollen muscle aches and swollen lymph glands. Typically, we're going to treat this with antibiotics because it is typically a bacteria that's causing these issues. They might do a lymph node biopsy if blood tests are not showing this. But just remember that every time we remove a lymph node, we don't grow a new one back, and we can lead to things like lymphedema if we remove more. So the picture on the top, I don't know who this is, but if I had to take a guess, she had breast cancer. They removed the lymph nodes in the armpit area, which then led to that lymphedema. So this is just going to be that chronic edema. Typically, we see it on one side versus another side, versus bilateral, so just unilateral. If it was bilateral, we start thinking things like cardiac in nature, like congestive heart failure. And this can be due to, again, that removal, but can also be due to damage and or if there's some parasites that you can get when visiting tropical locations that can cause this. And that is cardiac conditions. Let me know if you have any questions.